Swayam Prabha. Digital India. Educated India.
In our previous class, this will be the continuation of pulmonary infections. If you can recollect, I mentioned there are 7 subcategories of pulmonary infections. In the last class, we spoke about community, acquired, typical pneumonia, and second one, community acquired, this is typical pneumonia and this is atypical pneumonia. So we know about these two entities. One more important point that I would like to highlight is when this infection, these are one of the most common type of pulmonary infections or pneumonia. What you should remember in this category is because it is acquired and occurring in the community, the causative organisms will be same for all the infected persons. Same causative organisms. Okay, all the individuals will have a similar kind of organisms causing pulmonary infections. Today, we'll see the third and one of the most important category is nosocomial pneumonias. The other name for nosocomial pneumonia is hospital-acquired pneumonia. What is this hospital-acquired pneumonia? Hospital-acquired pneumonia. I'll give you an example. I'm a healthy individual. I'm going and admitting in a hospital for some other reason. For example, if you say I met with an accident and my lung function priorly was perfectly fine. After admitting in hospital, I got operated for the fracture. Then after admitting in hospital, about 1 to 2 days, 24 to 48 hours, 24 to 48 hours. That means within 1 to 2 days, along with my primary fracture, I will get some kind of a pulmonary infections. That we categorize, we call it as nosocomial pneumonias. That means nosocomia by Latin, nosocomia or it means hospital. These are hospital acquired pneumonias. Why it is important? Why they have separately categorized this entity? It is very important because before I go to those things, but 3 more important word that you should remember is that you can see in the PowerPoint. One is hospital acquired pneumonia that I mentioned you just now. Hospital acquired pneumonia, that means any individuals who does not have any kind of a respiratory infections admitting in hospital, and after admission of 1 to 2 days you'll get pulmonary infections. Those we call it as hospital acquired pneumonia. The second subcategory in the same is ventilator associated pneumonia. Ventilator associated pneumonia. See, this we call it as VAP, ventilator associated pneumonia. Patients who are put on ventilators, they are also more prone to develop lung infections. So those categories, they again called it as ventilator associated pneumonia. And in general, the most commonly nowadays the terminology is used is healthcare related associated pneumonia. This healthcare associated pneumonia. This we call it as healthcare associated pneumonia. So these are the 3 important subtypes. If somebody uses ventilator associated pneumonia, you should know what exactly it means. Healthcare associated pneumonia and hospital acquired pneumonia. Why we are highlighting or why we are giving more stress for this hospital acquired pneumonia? Because in the first 2 category I mentioned, the causative organism is same. That is, single organisms causes multiple infections. But in hospital acquired pneumonia, the causative organisms is usually the mixture of gram positive and gram negative organisms. We have gram positive organisms, gram negative organisms. So you need to treat for both gram positive antibiotics, which are sensitive organisms, and antibiotics which are sensitive to gram negative organisms. Second most important thing is pseudomonas infections. Most of these pseudomonas organisms, most of these nosocomial or hospital acquired pneumonias, they are infected with pseudomonas. It is very dangerous and it is highly virulent. It is highly virulent. That means most of these organisms, they are antibiotic resistant. They are resistant to normal antibiotics. So it is very difficult to treat these patients. One more important organisms which causes hospital acquired pneumonia is staphylococcus aureus. Staphylococcus aureus. Pseudomonas infection, Staph aureus, they are highly virulent organisms. They cause more damage to the lung, and these are the organisms which causes more prominent lung abscess. And these hospital acquired organisms which are present in the hospital, they are most commonly resistant to antibiotics, and hence it is difficult for the clinicians to treat. So improvement may not occur in these patients. Along with that, there is a mixture of both gram positive and gram negative organisms. These are all, we call it as multi-drug resistant organisms. Multi-drug resistant organisms. Okay. What are the key points that you should remember in case of nosocomial or hospital acquired pneumonia? One is, when the patient is infected in the hospital, so hospital acquired pneumonia is one of the most common and the leading cause of death. So these patients will have high mortality and morbidity, increased mortality. Hospital acquired infection is one of the most common cause of hospital induced death. Okay. Second one is, when you see the pathogenesis, most of these organisms, they are inhaled and they are colonized from the tracheobronchial tree or in the mouth. Okay, these are the pathogenic organisms which are colonized in the mouth. Or we can say oral cavity. And these organisms, they later on aspirated into the lung, causing damage to the lung, that is pneumonia or lung abscess. Okay. And most important is, these organisms, how to prevent this, how to treat it is these are the key points, very difficult to treat. Prevention and treatment is difficult. Prevention and treatment is very difficult in these organisms. And what you should remember is, whenever any patient is admitted in hospital, and to prevent hospital acquired pneumonias, one of the important preventive measures what you can take, or you can say that these patients, they can have increased or good oral hygiene. If you maintain good oral hygiene, you have a less chance of developing hospital acquired pneumonias. But still, it is very difficult to prevent. Fine. So we know the definition of hospital acquired pneumonia, what are the organisms causing hospital acquired pneumonia, and why they are more important. These are all very virulent and multi-drug resistant organisms. What are the key points that we should remember in nosocomial pneumonias? Let's see the pathophysiology. What exactly happens? I'll leave this. I will erase community acquired pneumonias. I'll keep the heading nosocomial pneumonias. nosocomial pneumonias. Right? What happens? When you see this, all of you know the trachea divides into two main branches. Okay, this is the right main bronchus and this is the left main bronchus. When you see, the right main bronchus is more in line, you can see that in the picture, is in more line with the trachea, and left main bronchus presents are located at little acute angle position. It's in more angle with the main trachea. So whatever you inhale or whatever any foreign body, whatever you inhale, it will directly goes and lodges in the middle and lower lobe of the right lung. So aspiration pneumonia, the most common location is right lung, middle and lower lobe, and you can see that tracheobronchial tree in the picture. So after dealing with nosocomial pneumonia, the next category is what we're talking about, aspiration pneumonia. The name itself indicates lung infection occurring due to aspiration. Aspiration may be anything. Okay, if you want to see the pathophysiology, what causes aspiration pneumonia, it's been very beautifully depicted in the presentation. See, three important things that you should remember. One, in normal individuals, when you are eating or drinking, there will be brain and swallowing axis. So when you eat or drink, the epiglottis will close the trachea, and whatever food or drink you take, that will go to the esophagus, stomach. So in any condition which impairs this process, this ultimately leads to ingestion or swallowing of liquids or solids into the trachea. Instead of going to the esophagus, they will enter the trachea, they will enter the lungs and causes secondary infections. So what are those conditions? Any kind of esophageal dysmotility. Esophageal dysmotility. Whatever the kind of what are all the causes leading to esophageal dysmotility, these patients are more prone to develop aspiration pneumonia. And any kind of chronic COPDs, they are also more prone to develop aspiration pneumonia. Any kind of esophageal strictures, where food cannot enter into the esophagus, that ultimately enters into the trachea, leading to aspiration pneumonia. Esophageal strictures, it can be due to cancer, malignancies, or any kind of inflammatory strictures. Important. Then you have important second category is impaired consciousness. Impaired consciousness. That means these are the patients, when any patient having neuromuscular disability, any patient who are comatose patient, any patient who is chronic alcoholic patient who are on general anesthesia. All of you should observe these things in the routine clinicals, and this is general anesthesia. Patients who are putting on general anesthesia. So these are the patients who are more prone to develop aspiration pneumonia. And we have reflux esophagitis, reflux gastritis. Reflux gastritis is one condition where the gastric content, if you have a stomach, the gastric content will go up and ultimately enters into the trachea, causing damage to the lung and forming abscess. This is reflux esophagitis, again one of the most common cause of aspiration pneumonia. And impaired cough reflex. impaired cough reflex. Whenever you have an impaired cough reflex, you have more chance to develop aspiration pneumonia. So these are the important causes that you should remember. One, any impairment in the swallowing, whatever may be the cause. The impairment in the swallowing, any impaired consciousness, any cause, any condition which causes impairment in the normal consciousness, reflux gastritis, reflux esophagitis, and impairment of cough reflex. So any of them, they are patients, they are more prone to develop aspiration pneumonia. Let's see. In aspiration, once the aspiration, any content, if enters the trachea, which part of the lobe or which part of the lung is most commonly affected? I'll go back to anatomy. You have a trachea here and right main bronchus and left bronchus. This is right bronchus and left bronchus. If you see, the right bronchus is in more line with the trachea, and you have a right lung here, left lung here. So whatever you ingest or aspirate, the foreign body or liquid directly enters to the lower part of the mid lobe or upper part of the lower lobe. So in aspiration pneumonia, the most common lobes or lungs affected are right lung, middle and lower lobe. Left lung is less commonly involved. You can see the anatomic diagram in the picture. So what all can cause aspiration pneumonia? So aspiration means most of the thing, it is from the mouth or from the food. Okay. So you have in the oral cavity, you have a mixture of both gram-positive and gram-negative organisms. Gram-positive and gram-negative organisms. So when you inhale the oral cavity contents, you will have a mixture of these two organisms causing pneumonia. And along with that, in intoxicated patients, other common organisms which causes aspiration pneumonia are Staph aureus. I told you previously, in hospital acquired infections, Staph aureus also, it's one of the most common organisms, and it is also very virulent organisms. And along with that, if you have a aspiration, the part of the gastric content will also enters into the lungs. So gastric content means acid. Acid, it is the more potent chemical which destroy any of the tissues. So when you have aspiration, you will have gastric content which contains acid, which destroys the lung. Along with that, you have secondary infection of these organisms. That's why in most of the aspiration pneumonia patients, these patients are more prone to develop lung abscess. Okay, why? One is chemical injury, destruction, and superadded infection. Most commonly, infection have both gram-positive, gram-negative organisms. If you want to treat aspiration pneumonia, you have to treat proper antibiotics which are sensitive for both gram-negative and gram-negative organisms. This is the X-ray. You can see this is the X-ray of a patient who had a history of aspiration pneumonia. All of you can see right lobe is relatively fine except for some haziness in the lower lobe, and when you see the left lobe, and right lobe, when you see, you are seeing a thick walled cavity in the lower lobes, cavitated. This is nothing but lung abscess. This is lung abscess. You still can make out some kind of a fluid here, gray white thick wall with some kind of a fluid. It is, radiologist will say that there is a lung abscess or cavitated lung in the right lower lobe. This is the X-ray of a patient who had aspiration pneumonia. Then how to diagnose these patients? Let's see detailed clinical history and the clinical scenario of these patients, and presence of the radiology is sufficient to say that it is aspiration pneumonia. If you still want pathological diagnosis, how it looks. Pathology means both macroscopy and microscopy. Microscopy means gross examinations. Gross. Usually, you will not get a gross lung or lobectomy in aspiration pneumonia unless until it has a severely involved and they have done lobectomy. The most commonly you might see these kind of cases in forensic pathology. So how it looks? So as I told you previously, the aspiration pneumonia is one of the most common cause of lung abscess formation. When you see the lung, we'll see multiple abscess or cavitatory spaces. All of you can see in that presentation. They have multiple cavities of variable size. They may be single, there may be multiple, and you will have a thick fibrous rim, and you might see some kind of an content or any necrotic content in the lumen. So all of you can see. Rest of the lung parenchyma will be normal. The lung parenchyma away from the lesion will be normal. The lung parenchyma which is adjacent here, it depends on the chronicity of the inflammation. So it may show consolidation, it may show mild pneumonic-like infection, inflammation, or it may show diffuse fibrosis depending on the duration. If you take sections from here, microscopic examination from the abscess cavity and the adjacent lung, what you can see for the diagnosis of aspiration pneumonia, you have to see presence of foreign material in the alveolar parenchyma, along with lot of destructive inflammation of the lung parenchyma. In that microscopic picture, you can see that you can make out the alveolar outlines. If you concentrate on septa, the septa are congested. That means there is an inflammation is going on, and when you see the alveoli are filled with various type of acute and chronic inflammatory cells. Actually, predominantly the acute inflammatory cells. You are seeing some kind of a proteinaceous exudate in some of the alveoli, eosinophilic material, what you can see there. Along with that, if you observe, there are some foreign material on the upper right corner. You can see those are the foreign material which is present in the lung parenchyma within the inflammatory zone. So identification of this foreign material, most commonly there will be vegetable matters, because aspiration, whatever they eat, it will enter into the lung. Most commonly you will see vegetable matters. If you see vegetable matters on microscopic examination, it is the diagnostic feature of aspiration pneumonia. Okay, there is one more microscopic picture, and you can see that arrow is pointing towards some vegetable foreign material lying with dense inflammation of the lung parenchyma causing destruction. So when you see this, it is the microscopic definition or diagnosis to say it is aspiration pneumonia patients. After aspiration pneumonia, we will see the next category, called it as necrotizing pneumonia. Necrotizing pneumonia. What is this necrotizing pneumonia? It is general classification. Any kind of a pneumonia, whether it is a community acquired or a hospital acquired or aspiration pneumonia, any pneumonia which causes abundant necrosis of the lung parenchyma, then extensive damage. Extensive damage of the lung parenchyma, we categorize all those categories as necrotizing pneumonia. Why it is important? It is important because certain organisms, they are more prone to cause severe damage to the lung parenchyma. So what are those organisms? One is Streptococcus pneumoniae. Streptococcus pneumoniae. As I previously mentioned, Staph aureus, Klebsiella, Pseudomonas, Klebsiella, Pseudomonas, Nocardia species. So when you have infection with these organisms, the lung will be severely damaged. That's why they categorized as necrotizing pneumonia. So these are the pneumonias which again more prone to develop lung abscess. Okay, again you have multiple complications of the lung abscess. So how actually it looks when you examine on microscopy? If you take sections of a patient who had necrotizing pneumonia, you will see only necrosis. You can see the microscopic picture here. You'll see only necroinflammatory exudate with extensive damage of the lung parenchyma. Other than that, you cannot find anything. If you can do any special stains for bacteria, demonstrations of bacteria, you can do gram stain for the demonstration of bacteria. You will see only complete necrosis, nothing else. So these categories we call it as necrotizing pneumonia. Okay, then we have a last category of pneumonia classification that we call it as pneumonia that occurs in immunocompromised individuals. Immunocompromised individuals. Pneumonia that is occurring in immunocompromised individuals. Why it is important? This because the organisms which are causing pneumonia in these individuals will not generally cause any kind of a lung infection in a healthy individuals. If you demonstrate these organisms, that means in any patient, that means that you have to rule out or extensively investigate for any kind of an immunodeficiency disorders. Most commonly in India, it is retroviral infection, HIV infections. So what are those organisms which are particularly or commonly occurs in immunocompromised patients? 1. Pseudomonas aeruginosa. Pseudomonas aeruginosa. These are the bacteria. Again, the causative organisms can be divided, whether it is a bacteria, whether it is a fungal, or it is a viral. So if you want to see the bacteria, what are the bacteria? Pseudomonas bacteria. In India or any developing countries, most common, I think we should mention Mycobacterium tuberculosis is the first. I'll mention it first. So MTB, Mycobacterium tuberculosis, is the most common organisms in any kind of immunocompromised states. Then Listeria monocytogenes. Listeria monocytogenes. Listeria monocytogenesis, pneumophilia. So all those bacteria, they most commonly causes lung infections. Next, we have viruses. So common viruses are cytomegalovirus. Cytomegalovirus. This is very important. This commonly will not cause any kind of infection in healthy or immunocompetent patients. When you have cytomegalovirus inclusions in any of the body, in any of your body, that means you have immunocompromised states. Then herpes virus. Herpes virus infections. Okay, whenever body immunity will low, the herpes virus will reactivate. Next comes the fungus. Fungi. What are the common fungi? You have Candida. Candida will be present as a normal commensal in many mucosal sites, but invasive Candida, when you see in any of the microhistopathology samples, that means it is a immunocompromised state. Then Aspergillus. These are the common fungi. Aspergillus species. You have Cryptococcus. Then pneumococcal. Pneumocystis carinii. Then histoplasma. So these are the things that you have to mention, a category, how it is categorized for pneumonia in immunocompromised states. There are some. So how to identify this thing is, you have two methods. One, if the biopsy sample is taken for any site, any body fluid like sputum or bronchoalveolar lavage, or any tissue biopsy specimens, you need to demonstrate these organisms. A detailed morphology and other characteristic feature of individual organisms, what I told you in the previous slide, you will be dealing those in detail with the microbiology. I will just highlight how individual the organisms will look like. Cytomegalovirus, how it looks, the name itself indicates. You can see that picture. Affected cells will become grossly enlarged and you will see prominent intranuclear eosinophilic inclusions. Cytomegalovirus viral inclusions. You can see the affected cells, they'll become popped up, they'll become enlarged. Then you have aspergillus fungi. Aspergillus fungi, how will you identify? They are the thin, true septate fungus which are branching at acute angle. Thin, true septate fungus with acute angle branching, we call it as Aspergillus species. You have in the center pneumococcus corny pneumonia. So these are the silver methylamine stain. Grocott, silver methylamine stain. And you have in this side, you have Candida species. These are the spores of the Candida, and this is the budding yeasts. Budding yeast forming pseudohyphal forms. You are seeing the yeast form, budding yeast forms, and also pseudohyphal forms of Candida. So Candida usually when they are not invasive, they will be in yeast forms. When they become invasive, they become budding and it forms the pseudohyphae of the Candida species. Again, you have special stains showing Cryptococcus fungus. This is the mucicarmine stain, special stains. So you can do special stains for all these organisms for demonstration. The most commonly used special stains are periodic acid shift diastase resistant, then Grocott silver methylamine stain. So these are the, by doing these stains you can highlight the organism and you can come to a definitive diagnosis. So this is in this last lecture we'll be completing the lung infections. Okay, all of you go back and read about lung infections.